There are diseases that trigger billions in funding within a matter of weeks. They mobilize laboratories, governments, technological platforms, supply chains, and emergency financing. And then there are those that are left waiting. When Ebola strikes the most vulnerable populations in Central Africa, it exposes the moral divide at the heart of global health. Emergency does not carry the same value everywhere. Human life does not always have the same strategic weight. And vaccines for the poor often arrive after the deaths. The latest illustration comes once again from the Democratic Republic of the Congo and Uganda. On May 17, 2026, the WHO classified the Ebola outbreak caused by the Bundibugyo virus as a public health emergency of international concern. As of May 21st, it had recorded 746 suspected cases in the DRC, including 176 deaths among suspected cases, as well as 85 confirmed cases, including 2 in Uganda and 10 confirmed deaths in both countries. The outbreak affects Ituri, North Kivu, and South Kivu in an environment already weakened by conflict, cross-border mobility, fragile health systems, and community mistrust. But the most serious issue lies elsewhere. This outbreak is caused by the Bundibugyo Ebola virus, for which there is currently no licensed vaccine and no approved specific treatment. On May 30th, 2026 in Bunia, WHO Director General Tedros Adhanom Ghebreyesus stated it clearly. This outbreak is caused by Bundibugyo virus, for which there are currently no licensed vaccines or therapeutics. On May 28th, experts convened by the WHO were still recommending that candidate products be used only within clinical trials. The most advanced vaccine candidate, a single-dose RVSV Bundibugyo vaccine developed by IAVI, would still need 7 to 9 months before being ready for preventive clinical evaluation. This is where the silent scandal lies. When a risk threatens wealthy economies, research turns into a race against time. When that same risk settles on the margins of the world, emergency becomes a protocol, an expert meeting, a promise in the pipeline. Manufacturers are not solely responsible. They respond to markets, purchase guarantees, and political and financial signals. But this is precisely the system that must be questioned. Why does science move so quickly when a solvent market exists, and so slowly when the victims are health workers, children, displaced people, and families living in eastern DRC? The paradox is all the more striking because a precedent exists. Since 2021, a global Ebola vaccine stockpile has made it possible to respond to outbreaks caused by the Zaire Ebola virus. In 2025, in the Congolese province of Kasai, more than 47,500 people at risk were vaccinated, helping to stop transmission within 1 month. The world therefore knows how to organize an emergency vaccine response. It knows how to build stockpiles. It knows how to target health workers. It knows how to carry out ring vaccination. But not all strains, not all regions, and not all lives have benefited from the same level of anticipation. Bundibugyo Ebola thus reminds us of a brutal truth. Global health does not merely lack vaccines, it lacks strategic equity. As long as emergency vaccines are designed around profitability, media visibility, and the interests of major powers, the most vulnerable will continue to wait. And in a hemorrhagic outbreak, waiting is never neutral. To wait is to let the virus count the dead before the world counts the doses.